Watch the planting leg as this athlete decelerates. At the apex of the movement, without physical contact from another player, the knee buckles inward. 70% of all anterior cruciate ligament tears occur exactly like this. They happen during rapid deceleration or sharp pivoting in high-impact sports, where the body's momentum is entirely self-inflicted. It presents an anatomical paradox. These are highly conditioned athletes, possessing immense muscular strength, yet their joints suffer catastrophic structural failure in open space. Before dissecting why this happens, note that this analysis is strictly for educational purposes. Always consult a certified medical professional for diagnostic and rehabilitation protocols. Understanding this sudden collapse requires looking past the knee as a simple hinge. It is a dynamic triad, a precise interplay of bone geometry, static ligament restraints, and neurological control. The knee operates with 6 degrees of freedom, managing flexion and extension, internal and external rotation, and varus and valgus stress simultaneously. This creates a severe vulnerability. The joint sits directly between the femur and tibia, the body's 2 longest lever arms. While the joint bears the massive compressive weight of the body through the femorotibial articulation, it relies entirely on a network of intra-articular ligaments to prevent the bones from subluxing or slipping out of place under those extreme leverage forces. Athletic survival is dictated by these internal ligaments maintaining absolute positional harmony. When that harmony breaks, the joint fails. Peeling away the patella and the joint capsule reveals the primary static stabilizers of the knee. Deep within the intercondylar notch, the cruciate ligaments cross each other in a distinct X configuration. The PCL is the ACL's thicker, stronger counterpart. At twice the cross-sectional area, it withstands 1,627 newtons, acting as a physical stopgap against posterior tibial translation. Its larger anterolateralbundle tightens in flexion, while the smaller posteromedialbundle pulls taut during extension. Opposing the PCL is the anterior cruciate ligament. It originates on the posteromedial corner of the lateral femoral condyle, specifically anchoring to a crescent-shaped bony landmark known as residence ridge. If the PCL serves as the joint's brute force anchor, the ACL operates as a highly sensitive multi-bundle constraint system tasked with managing rotational shear. For decades, the ACL was viewed as a single thick band of tissue. However, modern cadaveric studies define the ligament as a specific 3-bundle architecture. The anteromedial or AM bundle originates posterior-superiorly on residence ridge, restraining anterior tibial translation during knee flexion. The antero-inferior posterolateral or Pinel bundle pulls taut in extension for rotational control. Finally, the anterolateral bundle attaches directly to the lateral meniscus at the crescent's apex. This architecture explains why athletes can suffer specific partial ligament failures. An isolated tear of the PL bundle, for instance, leaves the knee vulnerable to severe rotational instability, even if the anterior restraint remains perfectly intact. In a clinical setting, this introduces the distinction between laxity and functional instability. Laxity is simply the passive physical translation of the bones. Instability is the active failure of the knee to support body weight. Severing these specific bundles permanently alters the joint's kinematic baseline, forcing surrounding structures to bear loads they were never designed for. Applying this architectural blueprint to a decelerating athlete reveals the exact mechanics of a non-contact tear. The phenomenon is known as columnar buckling. The failure sequence requires specific conditions. It initiates when the knee is caught in a shallow flexion angle, between 0 and 30 degrees, during deceleration. At this shallow angle, an unmitigated quadriceps contraction pulls the patellar tendon, creating extreme anterior shear force that draws the tibia forward. Compounded by an inward collapsing valgus moment and internal rotation, this multiplanar twisting maximizes tensile strain across all ACL bundles simultaneously. The final catalyst is the foot's position. Landing flat-footed neutralizes the calf muscles, preventing them from absorbing incoming ground reaction forces. Without the calf muscles to dampen the kinetic impact, the leg is converted into a rigid 2-segment column that cannot safely dissipate the energy. The joint undergoes columnar buckling. The lateral femoral condyle slides posteriorly over the tibia,
instantly exceeding the ACL's ultimate tensile threshold of 2,160 newtons. Alternatively, if the inward valgus collapse is paired with external rotation, the ACL physically impinges against the hard medial border of the femoral intercondylar notch, acting like a guillotine on the ligament. A non-contact tear is never a random accident. It is a precise, catastrophic mechanical failure, dictated entirely by multiplanar vectors surpassing a structural limit. The physical rupture of the ligament also destroys the joint's proprioceptive afferent feedback. The ACL is deeply embedded with mechanoreceptors, specifically Ruffini endings and Pacinian corpuscles. These nerve endings constantly feed joint position and acceleration data directly to the central nervous system. When the ligament snaps, these neural pathways are severed. This results in delayed hamstring reflex latencies, stripping the athlete's body of its subconscious ability to quickly pull the tibia back during dynamic athletic movements. Yet a specific subset of athletes, known clinically as copers, manage to return to high-level pivot sports despite having a completely ACL-deficient knee. Copers achieve functional joint stability through intense biomechanical adaptation. They subconsciously alter their neuromuscular patterns, maintaining a continuous, rigid co-contraction of their hamstrings and quadriceps to actively mask the structural laxity. In contrast are non-copers. These individuals suffer from severe functional instability and quadriceps inhibition and recurrent episodes of the knee giving way and buckling during mundane daily tasks, like walking down a flight of stairs. The clinical pathway an athlete takes is ultimately dictated by this neurological capacity. The decision relies on whether their nervous system can dynamically stabilize an inherently unstable architecture. For non-copers, surgical anterior cruciate ligament reconstruction is required to physically restore the joint. Anatomical tunnel placement is critical here. The surgeon must drill into the bone to precisely recreate the anteromedial and posterolateralbundle footprints on residence ridge. This chart shows return to sport success rates. For athletes undergoing surgical reconstruction, 83% successfully return to their pre-injury baseline. When non-copers attempt the conservative approach, that figure drops significantly. Only 19% return to their prior level of competition. However, targeted conservative rehabilitation and prehabilitation remain vital. Specific resistance training actively reduces tear risk by building the dynamic secondary stabilizers that protect the joint. Bilateral exercises, such as wide and lateral squats, are highly effective at building glute and frontal plane stability, which is necessary to absorb those joint-destroying inward valgus forces. Meanwhile, unilateral closed kinetic chain movements, like lunges and Bulgarian split squats, train the intense hamstring and quadriceps co-contraction. This muscular coordination acts as an active internal brace against anterior shear. True knee stability is the perfect harmony of an intact structural blueprint and precise dynamic muscular execution. If you found this biomechanical breakdown valuable, like the video, share it with a fellow athlete, and subscribe for more technical deep dives.